All right, if you're gearing up for your nursing boards, you know high alert OB meds are pretty much guaranteed to show up. So today we're doing a super fast, no fluff review of the safety points you absolutely have to know to pass. Let's just jump right in. Seriously, let me ask that again. Are you really ready? Because these are the kinds of meds that pop up all the time, not just on a test, but in those real-life, high-stakes moments where you are the one who has to make the right call and you have to do it fast. So just take a deep breath. We're going to build up that confidence by zeroing in on only the most critical, must-know safety information. By the time we're done here, you'll be able to spot the risks and know the interventions like the back of your hand. Okay, our first big scenario is probably the most common one you'll face in labor and delivery. You've got a patient with contractions, the doctor's orders in, but what's the goal here? Are we trying to get this show on the road, or are we slamming on the brakes? This is your very first decision point. Think of these meds as two totally opposite teams. On one side, you've got the tocolytics. They're the stop team. Their whole job is to suppress preterm labor. Think drugs like terbutaline. And on the other side, you've got the uterotonics, the go team. Their purpose is to induce or strengthen labor, and the team captain is definitely oxytocin. For your exam, you have to know which team you're playing for and what the ultimate goal is. Let's take a closer look at Team Stop. First up is terbutaline. Here's what you need to remember for your test. It is for acute, short-term use only. Why? Because it can cause major maternal tachycardia and serious cardiac problems. It even has a black box warning for it. That is a huge red flag. Then there's indomethacin. The keywords you need to associate with this drug are limits. It can't be used for more than 2 or 3 days and never after 32 weeks of gestation because it can cause a serious heart issue in the fetus. Those are hard and fast rules, non-negotiable. And now for the star player of Team Go, oxytocin, which you'll probably know as Pitocin. Its job is simple: make the uterus contract. We use it to get labor going or to control bleeding after the baby is born. But, and this is so important, it is one of the highest alert medications you will ever hang. It needs your undivided attention and constant monitoring, because when things go wrong with oxytocin, they go wrong really, really fast. So what do you do when oxytocin works a little too well? Your patient develops something called tachysystole. That's more than 5 contractions in a 10-minute window. This is a full-blown emergency because it can cut off blood flow to the baby. So what's your first move? Your only first move is step 1. Stop the infusion. Before you do anything else, turn off the Pitocin. Then you can do the other stuff. Get the patient on our side, give some oxygen, keep the IV fluids running, and call the provider. You have to memorize these steps in this exact order. All right, let's shift gears to our next high-stakes situation. You have a patient with severe preeclampsia. Her blood pressure is through the roof, and the biggest, scariest risk hanging over her head is a life-threatening seizure. Your job is to make sure that does not happen. So picture this NCLEX question in your head. Your patient is on a drip to prevent seizures. You go in for your assessment. You check her deep tendon reflexes, and they're gone, absent. You count her breaths. It's only 10 per minute. What is the giant flashing alarm bell going off in your head right now? Your immediate concern has to be medication toxicity. And the drug causing this is magnesium sulfate. Now, the NCLEX loves to try and trick you on this one. While mag sulfate might bring the blood pressure down a little, that's just a side effect. Its main job, its whole purpose in this scenario, is to act as an anticonvulsant. It calms down the central nervous system to prevent seizures. So remember, it is not an antihypertensive. Okay, this is one of those numbers you just have to burn into your brain. The therapeutic window for magnesium sulfate is super narrow, 4 to 7. If the level is below that, she could have a seizure. If it's above that, you're looking at life-threatening toxicity. You've got to know this range. So how do you spot toxicity without even looking at a lab value? You use your incredible nursing assessment skills. These are the classic signs. Is her respiratory rate under 12? Are her reflexes completely gone? Is her urine output dropping below 30 milliliters an hour? Is she getting sleepy and hard to wake up? Any one of those is a massive red flag telling you that her magnesium level is toxic. And if you suspect toxicity, you need the antidote, and you need it right now. The antidote for magnesium sulfate toxicity is calcium gluconate. As the nurse, it is your job to make sure this is sitting at the patient's bedside before you even start the magnesium drip. That is a critical safety check. Okay, on to the next emergency. The baby is out, everything seems great, but the danger is not over. Your patient is now bleeding. A lot. You're now in a race against time to manage a postpartum hemorrhage. The intervention you'll often see here is methylorgonavane, or methergine. I want you to think of this drug as a powerhouse. It's a super potent uterine stimulant that just makes the uterus clamp down hard, squeezing those open blood vessels shut and stopping the bleeding in its tracks. Now listen up, because timing is everything with this drug. This is a rule you can never, ever, ever break. You only give methergine after the placenta is delivered. If you give it before, the uterus could clamp down on that placenta, trapping it inside, which could lead to a catastrophic uterine rupture. And now for the single biggest contraindication you have to know for the exam: hypertension. Methergine is a vasoconstrictor, meaning it squeezes blood vessels. If you give this to a patient who already has high blood pressure, you could literally trigger a hypertensive crisis or even a stroke. So what's your number one nursing action before you give this drug? Always, always, always check the blood pressure. All right, our final high-alert scenario revolves around pain management. Your patient has an epidural, which usually contains some pretty powerful opioids. And while it works wonders for pain, it also carries a huge risk that you, the nurse, have to be watching for constantly. Here's the test question. You walk into the room and your patient with the epidural is really sleepy, she's hard to wake up, and when you count her respirations, it's only 9. What is your priority? What do you do right now? This is a textbook sign of opioid-induced respiratory depression, and it requires you to act immediately. Your main responsibility here is just relentless monitoring. The number one risk of epidural opioids is respiratory depression, period. You might see a test question about how often you need to assess. It can be as frequent as every 15 minutes. You're checking their breathing, their O2 sats, their level of consciousness. You are the human safety monitor. And when your assessment spots a problem, you act. The life-saving antidote for an opioid overdose is naloxone, which you probably know as Narcan. This is the reversal agent that will immediately boot the opioids off the receptors in the brain and get your patient breathing again. Phew! Okay, we have covered a ton of ground. So let's lock all this knowledge in with a final rapid-fire safety checklist. These are the non-negotiable rules you need to have in your back pocket when you walk into your exam, and more importantly, onto the floor for your first job. Let's drill it. Ready? Oxytocin. Contractions are too close together. What do you do first? Stop the infusion. Terbutaline. Is it for long-term use? Absolutely not. It can cause maternal death. Methylorgonavane. What's the one vital sign you have to check before giving it? Blood pressure. And magnesium sulfate. What are you watching for and what do you need at the bedside? You're watching respirations and reflexes, and you have calcium gluconate ready to go. And we're going to end on this thought. Because more than any doctor's order, more than any pharmacy check, you, the nurse, are the final safety check. You're the one at the bedside who assesses, who questions, and who intervenes. After this review, I really hope you feel more prepared, not just to ace your exam, but to be that essential, life-saving safeguard for your patients. You've got this. Good luck.